Hello, my name is Sophia Hallisey, and I'm a third-year obstetrics and gynecology resident at Ascension Providence Hospital in Southfield, Michigan. My residency education is affiliated with Michigan State University's College of Human Medicine. Dr. Angela Maris is my faculty advisor for the research project titled Gestational Weight Gain and its Effect on the Success of Trial of Labor After Cesarean. According to the Center for Disease Control, the prevalence of obesity in America was 42.4% in 2018. Specifically, as depicted in this map, the prevalence of self-reported obesity in Michigan ranged from 30 to 35%. As such, many women who are pregnant are also obese, and these together have been associated with increased risks. The implications of obesity in pregnancy have been studied and known to be associated with increased maternal, neonatal, and birth-in risk. As there is increased risk of cesarean delivery in women who are obese, then there are inherently increased operative risks in this patient population. At this time, the National Academy of Medicine has published weight gain recommendations for pregnancy with a 25 to 35 pound weight gain range for normal weight women, those with a BMI between 18.5 to 24.9, versus an 11 to 20 pound weight gain for patients categorized as obese. These recommendations are based on the premise that the amount of weight gain during pregnancy can affect both the immediate and future health of the woman and her infant. As previously discussed, women who are obese have an increased risk of undergoing operative delivery, i.e. cesarean section. There are typically two options for subsequent delivery for these women. The first is a repeat cesarean delivery, while the other is termed trial of labor after cesarean, named TOLAC. If the TOLAC is successful, we term this a vaginal birth after cesarean, or VBAC. However, careful consideration must be entertained when considering these options. When discussing TOLAC attempt with patients, weighing the maternal and neonatal risks and benefits should be considered. This table demonstrates how both mother and infant can be affected by an attempt at VBAC. Thorough patient counseling is essential. Some practitioners stratify TOLAC candidates based on demographic and obstetric characteristics. Factors that have been known to negatively influence likelihood of VBAC include advanced maternal age, high BMI, high birth weight, and advanced gestational age at delivery. Gestational weight gain, or weight gain in pregnancy, and its association with successive VBAC has been previously studied with differing outcomes. One such study was published in 2005 by Jewesh and Al and demonstrated that excessive weight gain during pregnancy and obesity decreased VBAC success. Later, Hibbert and al. In 2006 concluded that increased BMI correlates with TOLAC outcome, and morbidly obese women were at higher likelihood of VBAC failure. In addition, increased BMI had a greater composite morbidity and neonatal injury. This study included almost 30,000 patients and was well-powered. However, a recent publication in the American Journal of Perinatology demonstrated no such association. This study included 614 patients and did not show statistically significant difference in outcomes. Their post-hoc power analysis showed that they were powered to detect a 12.5% difference in TOLAC success rates. The object of our study was to further verify these findings with a larger study population and to determine whether gestational weight gain truly had an effect on TOLAC outcomes. We conducted a retrospective data analysis with selected patients who had a history of a prior low transverse cesarean section between the years of 2010 and 2019. We included all patients who attempted TOLAC between the ages of 18 to 55 and who were admitted to the labor and delivery unit at our institution. From these data, we subdivided the patients based on gestational age, with term populations being greater or equal to 37 weeks and the preterm population between 32 and 37 weeks of gestation. Assuming a normal BMI prior to pregnancy, gestational weight gain was divided between less than 25 pounds of gestational weight gain, the second between 25 to 30, and the third category being greater than 35 pounds. Data analysis was performed using IBM SPSS with chi-square analysis to determine associations between discrete variables and the student's t-test for continuous variables. A p-value less than 0.05 was considered significant. Inclusion criteria included any female undergoing TOLAC at greater or equal to 32 weeks of gestation, a vertex singleton gestation, and a history of a single prior low transverse cesarean section. Exclusion criteria included any current intrapartum fetal demise, a gestational age less than 32 weeks of gestation, or no recorded weight gain. After application of the criteria, 950 patients were included in the study, 877 were term while 95 were preterm. In the term and preterm population, patients with successful VBAC were just as likely to be in any of the weight gain groups. A total of 667 patients had a successful VBAC, whereas 283 were unsuccessful. There was no demonstrable association between gestational weight gain and the likelihood of successful VBAC. Our study found no association between the amount of gestational weight gain and TOLAC success. Even when further subdivided for recommended weight gain in pregnancy, no association was demonstrated. These results confirm the findings proposed by May and Al in 2019, though this study had limited power and included only 614 women. Our results equally contrasted with previously published data by failing to demonstrate any significance between the failed TOLAC group and gaining more than the recommended gestational weight gain. A possible hypothesis for the difference in findings include the earlier study dates, almost 20 years ago, when TOLAC may not have been encouraged and less was known about the risks and benefits. During prenatal care, a thorough discussion with patients regarding TOLAC is essential to proper care. While our data did not demonstrate increased risk of repeat cesarean section with greater gestational weight gain, promoting proper health maintenance is still of great importance. Limitations of this study were a discrepancy in how weight was recorded upon presentation to labor and delivery, the risk of possible selection bias with our research being conducted retrospectively, and the lack of interface between electronic health record platforms limiting the availability of demographic data available on our study patients. We must also consider that gestational weight gain recommendations differs from pre-pregnancy weight, and our study did not take this into account given the lack of available pre-pregnancy weight data. The largest strength of our study includes a large population of patients, giving our results greater power and increased reliability. I thank you for your time.